I'll do your intro, ma'am, and then you can take over.
Yeah.
So, can we start, ma'am?
Yeah.
So, ma'am is 3, 2, 1. Over to you, Sanjana, ma'am. We are live to audience platform.
Okay. Very good afternoon to everyone. My name is Dr. Sanjana Shastri, and I'm from the medical team of Cipla Respiratory. It gives me great pleasure to invite you all to the event New Avenues in COPD Management, which is a part of our Evolve webinar series. And we have an exciting agenda planned for you all today with an esteemed faculty helming this program. Our moderator for today is Dr. Sonam Solanki. She's the director of the Inisio Chest Clinic in Mumbai. She's affiliated with prominent hospitals in Mumbai, from Breach Candy to Bhatia Hospital, and she's also received additional training in bronchoscopy, medical thoracoscopy, immunology, and interventional pulmonology. So, with this, I hand over the session to you, Dr. Sonam.
Hi, good afternoon, everyone. Thank you, Sanjana, for the introduction. So, what we are going to do in the next 1.5 hours is discuss new avenues of management in COPD. So we'll have a quick lecture initially, followed by a panel discussion. For the talk, I would like to introduce Dr. Manu Madan, who is a senior consultant and head at Medanta Hospital, Noida. He's been the editor-in-chief Pulmonary Update in 2021 to 23, and he has more than 50 publications. Of course, he's a MBBS, MD, and DM pulmonary and critical care sleep medicine. Followed by the talk, we'll have a panel discussion with our esteemed faculty. Dr. Nitin Abhyankar, we all know and have learned from him at various platforms. He's a consultant and HOD at Pune Hospital, Pune. He's the course director of respiratory therapy in Pune Hospital, and we know that he's got keen interest in interventional pulmonology. He's a founder of School of Interventional Pulmonology at Pune Hospital and has trained over 25 fellows, 9 observers over the last 10 years. Another person on the panel is Dr. Purvi Devani. She is a cardiovascular and respiratory physiotherapist. She's at the Pratibha Prabhakar Pulmonary Rehab Center in Mumbai, also a visiting faculty at Nanavati Hospital, treasurer of the CVPR, ERS member associated with the NAPCON, and conducted multiple workshops in pulmonary rehab during COVID also. And she is an awardee of the Maharashtra State IAP COVID Warrior in 2021. We'll be joining amongst us pulmonologists and physiotherapists. We have a cardiologist, Dr. Priyank Modi, who is MBBS, MD, and DNB cardiology. He has his own center, Dr. Modi's Advanced Cardiac Care Center in Surat, and he's affiliated with the Texas Heart and Sanjeevani Hospital, Divine Hiba Hospital in Surat, affiliated with hospitals like Breach Candy, KJ Somaya, Hinduja, etc. And he has a special interest in interventional cardiology, complex coronary intervention, 2D echo, cardiography, TMT Holter, and has numerous publications to its credit. So with this, I think we'll start with our talk. And over to you, Dr. Manu Madan.
Dr. Manu sir.
I'm trying to share my screen.
Yeah.
I'm not allowed to. Is this screen visible?
Yes.
Okay. Good afternoon, everyone. Good afternoon, seniors, colleagues, and dear friends. I'll be talking about interplay of COPD and cardiovascular diseases, implications of clinical practice. So first of all, we should know why comorbid CVD is dangerous but a common lesion. In the case of COPD, you have shared risk factors with CVD, like smoking, like biomass, elderly, air pollution if you're living in a NCR or a highly polluted metropolitan city in India. So you have shared risk factors. That is one of the common reasons. Secondly, when you have COPD, you have problems like exacerbations. Exacerbation itself, we'll talk about in later slides as well, leads to cardiac decompensation and other cardiovascular problems. When you talk about hyperinflation, just the hyperinflation will affect the afterloads and preloads. If there's excessive hyperinflation, you'll have decreased preload of the right ventricle and increased afterload for the right ventricle. If we talk about left ventricle, the preload decreases with hyperinflations. So there is ventricle wall stress as well. in the cases of COPDs. It has been seen that if there is ventricle wall stress, it might lead to left ventricular dysfunction as well directly without causing preload and afterload changes. Then there's hypoxemia. Hypoxemia is leading to systemic inflammation, and systemic inflammation is further causing arterial stiffness, which will lead to exercise intolerance and deconditioning. All these will lead to increased CV risk. When you have cardiovascular risk or diseases, then it will further lead to exercise intolerance, it will worsen your dyspneas, and systemic inflammation will further increase. Thus, prevalence of CVD among COPD patients is up to 70% and around 30% in asthmatics. So, how if we compare various comorbidities, especially of cardiovascular disease and COPD, we'll find that frequently they coexist with an estimate around 30 to 60%. Cardiovascular events are one of the most common reasons for hospital admissions. 30 to 50% of deaths in patients with COPD are primarily driven by underlying CVD. If you see this graph, hyperlipidemia and hypertension account for the maximum prevalence in this group, which is more than 40%. If we talk about ischemic heart diseases, it's around 30%. We talk about heart failures, again, it's reaching 20%. Atrial fibrillation is in the range of 10 to 14%. And other risk factors, other comorbidities like CVAs and aortic dissections also are in the range of 5 to 6%. When you have an exacerbation in such patients, it leads to further deterioration in the condition. The step ladder pattern decrease in patients' lung function. And only 50% patients are alive within 3.6 years of their first severe exacerbation. So even one moderate exacerbation will increase your risk of cardiopulmonary related deaths. Thus, controlling the exacerbation becomes the primary thing when we talk about all the trials or management of COPD. So if you have had a moderate exacerbation in your patient, initially the risks are very high. You might have risks up to 2 times of developing a cardiovascular event, which might persist up to 90 days to 1.6 times. If you had a severe exacerbation, this risk might persist up to 90 days and it is still 3 times greater risk than what a normal population would be. It is seen that overall risk might be persistent up till a year even. So why does CV safety matter in COPD patients? When COPD and CVD are co-occurring, as we can see in ischemic heart diseases, 11.4% of concomitant COPD patients have ISD. And if the patient is ISD, you'll see 30.5% patients have airflow limitation, which is undiagnosed and under-evaluated by the cardiologist, I would say. Same is the case with heart failures and atrial fibrillations. As you see, 37% airway obstruction patients will have chronic heart failure, while 17% patients with ventricular dysfunction might have COPD. Regarding atrial fibrillation, 10 to 15% patients of COPD patients might have AF. CVD is associated with higher morbidity and mortality in these patients. Increase of risk of death in those patients associated with CVD is ranged from 40 to 70%. As we discussed, COPD populations carry a high burden of CVD risk factors. Smoking is there, air pollution, biomass. But what happens is when you have COPD, you have systemic inflammation, you'll have increased chances of having diabetes, hypertension. You'll further increase the risk for ischemic heart diseases, acute coronary events, etc. If you see this diagram, you'll see that because of cigarette smoking, biomass, hypoxemia, oxidative stress, aging, etc., this leads to inflammation. This inflammation is further bidirectional with other comorbid illness. For example, if we talk about diabetes and obesity, it will worsen with inflammation. And this diabetes obesity will further worsen the inflammation as well. Similarly, inflammation will cause psychiatric problems like depression, anxiety, and this will even worsen your inflammation. So it's a bidirectional relationship. Same is the case with cardiovascular outcomes like hypertension, stroke, atrial fibrillation, renal failure, or if it's musculoskeletal, osteopenias, sarcopenias, cachexias. And when you have one of these like atherosclerosis or obstructive bronchitis, they go hand in hand. If you have obstructive bronchitis, it might lead to exacerbation, emphysema. And as I talked about, when you have emphysema, excessive hyperinflation, you'll have a lot of variations in your afterload and preload will affect your heart as well, which might lead to heart failure, myocardial dysfunction, and even myocardial infarctions. So there's an overlapping relationship between COPD and CVD. Patients with comorbid COPD and CVD experience worse quality of life, dyspnea, and exercise tolerance. 63% of patients have higher risk of hospital admissions. Acute exacerbation of COPD patient increases risk of cardiovascular events. So risk of cardiovascular events is significantly increased during moderate and severe exacerbations. So as you have discussed, there bidirectional relationship is seen between heart failure, ischemic heart disease, pulmonary hypertension, etc. So what is the impact of hypertension in COPD? COPD and hypertension are major health problems. Hypertension is one of the most commonly observed comorbidity in COPD patients, and prevalence of hypertension is very high, 37 to 65%, as we had seen in the initial graph as well. So very severe COPD patients tend to have increased risk of hypertension, owing to the fact that there is increased systemic inflammation, there is increased arterial wall thickness, which will all contribute to the hypertension. Patients with hypertension had 1.6 to 1.68 times higher risk of developing severe and very severe COPDs compared to those without hypertension. There was a UK cohort of 39,000 patients which found that there's increased risk in CVD risk. There is increased CVD risk with rising systolic BP, indicating elevations in hypertension can further increase your CVD risk in COPD patients. If we talk about cardiac comorbidities and COPD, as we have discussed already, so there's a bidirectional relationship. One will worsen the other. Prevalence of systolic and diastolic heart failure in COPD patients ranges of 20 to 70%. 40% COPD patients that are mechanically ventilated have evidence of left ventricular dysfunction. Unrecognized heart failure may accompany acute COPD. Regarding CAD and COPD, there's increased severity and extent of coronary lesions. There's calcific plaques, calcium score is increased because of systemic inflammation as well. When you talk about ischemic heart disease, the increased risk of adverse events. For every 10% decrease in FEV1, you might have increased cardiovascular mortality by 28%. 2.3-fold increase in MI after ACOPD. Previous ST and concomitant COPD are 4-fold increase in length. So this was given by one of the review articles which suggested that since we have a bidirectional relationship, it's not unilateral that COPD is causing the cardiovascular outcomes, you should evaluate both when at the outset. So you have a patient of COPD, you should evaluate with the help of NT-proBNPs, CRPs, ECGs, if there is associated cardiovascular component as well, cardiovascular disability as well. But same goes for our cardiologist colleagues. This is often understated that since we had discussed a decrease in FEV1 by 10% increases the risk of mortality, cardiovascular mortality. So it is very important that you monitor spirometry even in these patients. You have to look for COPD and other respiratory problems in a cardiological case as well. If you talk about acute setting, and it is very important that you evaluate the patient in great detail. Don't think, this is a general message for all the students, don't think that every dyspnea is because of COPD. At the outset, you have to look at the possibilities of other alternative etiologies like heart failures, MI. You should miss out if you only treat the patient for COPD. So at the outset, try to get a CBC done, CRP, fibrinogen, tropies, NT-proBNP, get an ABG done, ECGs, X-rays, D-dimers, echoes, and thoracic CT if required. So these again, as we have discussed, these are overlapping diseases and one treatment will affect the others as well. So if you are treating the cardiac part optimally, it will reflect in your dyspneas for your COPD patients. So in any case scenario, you have to treat the comorbidity aptly. So if the patient is a case of hypertension, you have to give cardioselective beta blocker. It will very commonly come across your cardiologist asking you, can I give a beta blocker? My patient has MI, my patient has cardiac difficulty, and I want to treat the patient as beta blockers. But there should be no hesitation while treating these patients. Give cardioselective beta blockers. If you control the patient's cardiac status, your overall patient health will also improve. So you have to treat them adequately, whether with the help of statins or cardioselective beta blockers, antiplatelet therapy, coronary revascularization if needed. And this will ultimately lead to decreased risk of exacerbations, bleeding complications might decrease, and less hospital admissions for MI and heart failure. If we talk about the triple therapies, what are the rules? So this is one landmark trial, the IMPACT trial. All of you must be aware of it. It was a 52-week randomized double-blind trial, phase 3. It was initially designed to enroll COPD patients with significant concurrent cardiovascular disease and risk. What they looked at was CV-ASI, which is CV adverse events on special interest, major risk cardiac events, time to first CVSI, and resulting in CVSI resulting in hospitalization, prolonged hospitalization or death. So it included 10,000 patients. Patients were divided in 3 groups. One was getting the triple therapy, fluticasone fumarate, umeclidinium, vilantrol, approximately 4,100 patients. And fluticasone vilantrol was having 4,100 patients again, while umeclidinium vilantrol has 2,000 patients. CV disorders and risk factors were similar across the treatment groups. At baseline, 29% of the patients had current or past cardiac disorder like coronary artery disease, arrhythmias, angina pectoris, MI, congestive heart failure. While 58% of the patients had a current or past vascular disorder like hypertension, CVA, carotid or aortofemoral vascular disease. Overall, 68% of the patients had at least one CV risk factor and 40% had at least two. What they found? They found that proportion of patients with incidence of CVSI across treatment groups was similar. Fluticasone, umeclidinium, vilantrol had 11%, fluticasone, vilantrol is 10%, umeclidinium, vilantrol at 11%. There was no significant differences between treatment groups with respect to hospitalized or fatal CVSI. Time to first CVSI event was also not significantly different. As you can see in this, there was no significant difference between the probability of events. So there was no significant difference between major acute cardiac events. And what they found was that in COPD population with CV risk factors, CVSI was 10 to 11%, MACE was 1 to 3%, and was similar across treatment groups, with no significant increase with fluticasone, including vilantrol. You have to understand this was to see if you are comparing a dual therapy with a triple therapy. So when you are comparing dual therapy with triple therapy, you are adding a drug, you want to see if adding onto a drug is causing any side effects. If it's not causing side effects and it's only causing benefit, the treatment might be beneficial. So when we talk about the other analysis they had done with the cardiopulmonary composite outcomes regarding severe exacerbations, all-cause death, and serious CVI, what they found was there was significant risk reduction in cardiopulmonary composite events as we had listed here. You can see here the green line is for umeclidinium and vilantrol. The orange line is for fluticasone and vilantrol, and the blue line is for fluticasone, umeclidinium, vilantrol. In most of these graphs, you will appreciate that probability of event was higher if the patient was not on inhaled corticosteroid. So if the patient was not on inhaled corticosteroid, the patient had higher probability of having an event. They were telling that triple therapies are significantly better than dual therapies, at least with respect if the dual therapy is not having ICS. And if we talk about severe pneumonias, you will see the reverse order. You will see that the blue line, which is the fluticasone, umeclidinium, vilantrol, tend to be on the higher side, while there is significant decrease in the severe pneumonias with umeclidinium, vilantrol. They were telling you severe pneumonias are lesser if there is no ICS. But if you see overall mortality, there is overall, this is all-cause mortality. You can see the all-cause mortality is lower with the triple therapy. The HR, the hazard ratio is 0.58 with the confidence interval of 0.38 to 0.88. They were telling you, despite patients having severe pneumonias, your all-cause mortality is lower, your severe exacerbations are lower. Now, you have to understand one thing based upon this, is that that these patients in which you are looking for the outcome, these patients, the impact trial had group B and group E patients. Not all patients were group E either. And one of the criteria they had used, that patients should have at least one moderate exacerbation, one severe exacerbation. They were telling you that if the patient has exacerbations, then going on to triple therapy might be beneficial because it will decrease your exacerbation, will decrease your mortalities. But if the patient is not having a severe exacerbation at all, and you increase the therapy to triple therapy, this might even worsen your patient, causing severe pneumonia. So you have to follow the gold guideline that it recommends choosing your therapies, choosing your ICS rightly. So time to first event for composite outcome, that is severe exacerbation or cause mortality. Again, that was better. You can see between the groups. And FF, fluticasone, umeclidinium, and vilantrol significantly reduce the risk of composite cardiopulmonary events. We talk about fulfill trial. Again, this trial included patients with both from group B and group E. That means you can have patients without exacerbation, or you can have patients with the better lung function and more exacerbations. So this was a randomized double-blind, double-dummy trial. It was a 24-week trial. They compared fluticasone, umeclidinium, and vilanterol with budesonide and formoterol. They had 1,800 patients in the one arm and 1,800 patients in total, rather, I beg your pardon. 911 patients in one arm of the triple therapy and 899 patients in the dual therapy, which had budesonide and formoterol. What they found was initially cardiovascular risk factors are similar in the two groups, and same was in the end. The cardiovascular effects were comparable in the two groups. Thereby, they said that 66% of the patients who had enrolled in fulfill trial had a CV risk factor present at enrollment. And treatment with fluticasone, imiclodipine, vilanterol, when observed over 24 to 52 weeks, showed no increase in CV risk. So again, it boils down to the factor that if you choose your patients rightly, you choose the patient who had exacerbations, and you plan to increase your therapy to triple therapy, you should not be worried regarding cardiovascular risk factors. Adding a therapy will not increase your risk factors. Same was seen with this study, which was umeclidinium added to fluticasone vilanterol. What they did was they compared three groups: imugladinium 62.5, imugladinium 120, 125, and placebo added to fluticasone vilanterol. Now, this was a double-blind placebo-controlled trial, randomized into 1:1:1. What they found was, as you can see, across the groups, regarding cardiovascular outcomes, cardiac arrhythmia, cardiac failures, cardiac ischemia, and stroke, they were comparable. There was no significant difference between the two arms, thereby telling you addition of umeclidinium to fluticasone vilanterol does not significantly increase the risk. So if it is not increasing your risk as such, not CV risk, but it does add to your decrease in exacerbations, it does improve your lung function. So yes, you can go for a triple therapy if you are adding it to fluticasone and vilanterol. Regarding choosing a cardiac agent in COPD patients, so as we had discussed, clinical outcomes with beta blockers in COPD. This was a trial. There have been multiple trials which have worked upon usage of beta blockers in obstructive airway disease, and this trial also found the same, that beta blocker at hospital discharge was not associated with increased risk of adverse outcomes in patients with COPD and acute MI, especially if the beta blocker is a cardioselective one, like a metoprolol. If we talk about ACE inhibitors and ARBs, there is a lot of literature which says that using ACE inhibitors and ARBs tend to decrease rates of pneumonias, severe pneumonias, and even mortality in patients with COPD. It might decrease the rate of progression of emphysemas, owing to the fact that this RAS pathway triggers the TGF pathway as well, and since TGF is blocked, you might have better outcomes in these groups. Although there is not much to choose between ARBs and ACE inhibitors, this was one study which had shown the comparison between ARBs and ACE inhibitors. It was published way back in 2011, but this was never confirmed as such. But in total, whatever the literature which is there at present does show that ARBs and ACE inhibitors tend to do, giving these to your patients, the patients tend to do well and might slow the progression of emphysemas. Regarding calcium channel blockers to treat hypertension, all that normal doses of like amlodipine of 5 mg does not cause significant problems, but higher doses like 10 mg might cause, because it's a vasodilator, might cause very weak mismatches. So if your patient is on CCBs and as having worsening after starting amlodipine, that patient is saying that now by oxygen I feel more fatigued, you should be wary of the fact that it can be because of CCBs, although CCBs are not contraindicated. CCBs are generally safe and you can use CCBs, but in an off case, when you know that you have recently started CCBs, if you experience some new symptoms, especially dyspneas, you should look at the possibility. You can use A gradient in your ABGs to see if the A gradient has worsened after starting CCBs. Regarding AFs, the presence of AF does not alter the treatment of COPD. Bronchodilators have been used previously and They are known to cause they're known proarrhythmic agents, especially these short-acting ones. But the long-acting ones are generally safe and well tolerated. So if your patient is having a AF, you will try to avoid short-acting bronchodilators. You try to avoid macrolides. We'll also try to avoid theophylline. So this is what it is about, that when you should act, it's basically that you are trying to teach yourself and your students that it's not restricted to lung. When you're giving a medication, it might affect your cardiovascular system, it might affect your diabetes if you're giving steroids without any rationale to your patients who has diabetes. So that might worsen his sugar. So you have to look at the other possibilities, that what your drugs might do to other systems and other organs in the body. You have to treat it as a holistic approach, I would say. So two key takeaways from this would be COPD is associated with 2 to 3 times higher cardiovascular morbidity and mortality. To minimize the risk of poorer outcomes, it is important to ensure that patients with comorbid COPD and CVD are managed effectively. Landmark trials like IMPACT, which we have discussed, include patients with CV morbidity like hypertension. Evidence showed that there is no statistically significant increases CV risk associated with just the triple therapy, including fluticasone, including Melanton, and reduce the risk of cardiopulmonary events. Evidence supports the use of beta blockers, ACE inhibitors, ARBs in COPD patients with cardiac comorbidity. Although with this I conclude, but there are a couple of things which are noteworthy to mention. Is the role of statins. During the 2010s, we had few trials which had shown that using statins in COPDs might be beneficial for COPDs as it decreases the inflammation. But it was later on refuted by the STATECOPE trial, which found that there is no significant difference. But if you have a patient who has hyperlipidemia, has an indication for cardiovascular indication for statins, it should not be withheld. And another important drug which is commonly talked about is aspirin, ecospirin, which we talk about. Yes, again, it has shown that it does not directly affect COPDs, but since COPDs tend to have cardiovascular events, it might be beneficial in those, owing to the fact that if you have a CV pathology, then again, this should not be withheld. With this, I conclude. Thank you.
Okay, thank you, Dr. Manumadan. Excellent. I think you have very well, and in detail described the cardiovascular angle when we see our COPD patient. And I think one of the, of course, you have the non-smoking COPD, but one of the common compounding factor is the smoking, the effect of smoking on the cardiovascular system and the respiratory system. But it is not limited to only the smoking COPD. I think that is another important thing to remember, that even the non-smoking COPD patients can have all of this, and our treatment approach should be the same. So with this, I think we move to the panel discussion. Yes, I think all our panelists are very well here. I've already introduced them. I'll just ask a couple of questions, and I would request you all to answer it. And the idea of this is not just to have a textbook answer, but we want our PG students to understand what to look for in clinical practice when they go for their rounds, when they're seeing the patients day in and day out. Right. So the first question is, in the Indian COPD population, Dr. Abhyankar, I would like to ask you this question. Which comorbidities are most frequently under-recognized, and what do you think are the most common reasons for this to happen?
I think in the Indian patients, the larger chunk of them being non-smoking, that's one. So I think, 60-65% of our Indian population has a non-smoking COPD, and therefore their analysis of their hypertension may not be up to the mark, because typically a smoker would be more likely to be screened for a hypertension much more rigorously. That is something which is very common. So that may not be all that sensibly done. The other thing which I think we may be underdoing is we are not evaluating their echos all that frequently as we should be, because once in a while, or you have a patient, though the numbers are not that high, but a coexistent pulmonary hypertension, particularly in patient who is in hypoxic state and is not on oxygen, generally tends to develop a coexistent pulmonary hypertension, and that also goes unrecognized because one doesn't look for a good 2D echo as a standard of care kind of a practice. You don't have to do it every day, obviously. It has to be done at least maybe once in a year, once in 2 years, depending on how, at what age the patient is and how is he progressing. For hypertension and hidden pulmonary hypertension, these two things come to my mind immediately. Uh, of course, I mean, apart from that, Manu has put in a laundry list of those other factors, but I think these two are a little different from.
One thing that I sometimes, I mean, again, this is not you, the nutritional status, the sarcopenia, the muscle loss, even that I feel is in clinical practice, and we have no tools. We are not measuring any skin.
Sarcopenia, we are just not
We are
measuring
not,
it.
yeah, we are not measuring anything.
We can see that they are gradually getting more cachectic. They breathe worse every day, and we still are not really able to control that because the anti-sarcopenia drugs are just on the horizon. They will be soon. We'll be flooded with them. But right now, our focus on sarcopenia has been missing. I have to concede that. Definitely.
Yes. And I think it is beyond our bandwidth, at least in our clinical practice, to sit and go over the nutrition and all of that. So I think that is one thing we all should keep in mind. So I'll move to the next question. Dr. Manu Madan, so according to Goal 26 report, that COPD is a part of multi-morbidity framework, right? It's not a single organ disease, which you very well this thing. So in your clinical practice, what do you do? Like when you see a patient, someone has referred, say a physician has referred, or someone has come to you, do you like have a checklist so that you don't miss out on any comorbidities, or how do you approach such a patient?
Yes, absolutely. Since COPD is a systemic disorder, not just a lung disorder, which we mistake it for. This systemic inflammation causes a lot of diseases which are not related directly to the lung as such. So what we do in our OPD is we try to actively look for diseases like hypertension, like cardiac dysfunction, especially diastolic dysfunctions. Um, then we look for anxieties, depressions, sarcopenias, as you said. Frailty is just another disease. If there's systemic inflammation, we obviously look for diabetes along with it. So we try to look for the major diseases which we do expect with COPD to happen. We don't assume that every respiratory illness, I would say every respiratory failure or every breathlessness is because of COPD. If a patient comes to me with breathlessness, I'll evaluate in detail. Yes, I'll get a PFT done, but I'll also get a BNP done, I'll get an echo done, I'll get a D-dimer done. I'll look at general condition of the patient. If the patient is frail, patient is having sarcopenias, is it deconditioning? I end up unnecessarily treating the patient for just deconditioning. Patient is not mobile. So these things I'll try to look for, and definitely the impact of your medications. Because one medication will impact the other systems since it's a systemic disorder. I should know, since we are not treating only the lung, we are treating the patient. I should know what is the diabetes status. I should not end up giving steroids to my diabetic patients who are already uncontrolled. I should not be giving steroids unnecessarily to patients who are osteoporotic, who have sarcopenias. I should know the status of their blood pressures, their arrhythmias. I should not. I'll get a lot of patients who have been prescribed Duolins and I should not take a brand name. Short-acting bronchodilators, non-judicially, and they end up in atrial fibrillations. So I should know their status. If they are prone for AFs. Do I need to control on the theophylline? Do I need to control on the short-acting blockers? So yeah, there's no checklist as such, but these are the broad things you will look at.
And even if you did have a checklist, it's not really complicated because a lot of our audience is PG students. So what we've been learning since MBBS, your pulse, BP, oxygen, the history. And in today's clinical practice, most government setup has the HMI system. You can look at the previous records. In my private clinic, I ask them to bring whenever even if the blood work is done or health checkup is done 6 months back, at least you roughly know what the patient has, and it's just a mental checklist of sorts, obviously. Great. Great. We move to Dr. Priyank Modi now, who is the cardiologist amongst us. So, from a cardiology point of view, Dr. Priyank, what are the key cardiovascular conditions that require systematic screening in COPD, and how do they influence long-term morbidity, mortality? We have obviously discussed here about getting echoes done, but from when as a cardiologist, when you listen to all of this, what is going on in your head when you say that, okay, I have to understand whether this patient has any cardiac comorbidities or not?
So one beautiful thing about a pulmonologist, like, or a cardiologist, so we have this like lifelong diseases and lifelong patients, right? So you would have a patient who's on your follow-up for 15, 20 years, and for him or her, that's the only disease he has. So let me put into perspective two important clinical scenarios. Now, this is just a last week thing. So this patient is still admitted, underwent a CABG 3 days before. So he's a 76-year-old gentleman. He just stays with his wife. He's known case of like COPD and takes inhaler on and off. He has nebulizer at home. So one night at 3 a.m., he suddenly was gasping for air. He became breathless. It was proper left ventricular failure or pulmonary edema. But the wife felt that it was a COPD exacerbation. He gave her a nebulizer and he was a little better. Then he went to sleep because they were alone, no family. And just 1.5 hours of sleep, and then he was gasping. And then they brought him in an ambulance to the hospital. We did an echo. The EF was 20%, troponin was 12,000. So it was an acute coronary syndrome. The pro-BNP was 77,000. Even for admission, I had to really explain it to the patient that it is hard because he was not even ready for an admission. And then we stabilized it, an angiography. It was a left main equivalent. He underwent a CABG. Safe. Now, again, this is not a very uncommon scenario. The first aspect to the patient is that they should also understand that along with COPD, they are still humans. Like a cardiac patient whom I have undergone angioplasty is going to call me 1 year later also that I have got diarrhea. And he would feel that it is the stent I have pushed has caused him diarrhea. So it's very common in our practice. So the first thing is that patient education you all should put across. Like you are still humans, right? So हमें malaria हो सकता है, हमें dengue हो सकता है. That can happen. It's not that you have COPD, so everything in your life is because of COPD. The second, and again, this is not a very uncommon thing, is whenever as a pulmonologist we label someone with a disease, like we 100% before, like screening and follow-ups are perfectly okay, but before we label them as a disease, at least first evaluation should be thorough. Like we have to rule out lot of things. The PGs here would be conversant with the concept of cardiac asthma. So it's not that bronchi will only happen on clinical examination with COPD. I've seen, and it's again not very uncommon. Every 3-4 months, this happens. Is like a person who has been treated for bronchial asthma or COPD, and he would have a valvular heart disease. So a 30-40-year-old is a rheumatic heart disease, mitral stenosis, had a cardiac asthma episode. They became better with nebulizer and things like that, and they have been on nebulizer. I have ASD patients who were treated as COPD for a long period of time and echo was never done. Particularly maybe in our urban areas, we would not miss upon some things. But a lot of this is like a general practitioner's mother who had an ASD was treated for asthma. So this is something that before you label a person, make sure we are clinicians, and once we give them a diagnosis, that is a diagnosis for them for lifetime. So before that, do a thorough evaluation, whether it is your pro-BNP or something else. Now, apart from these two clinical scenarios, the three cardiovascular conditions, the first is to rule out coronary artery disease because the risk factors are pretty much the same. And a patient who's particularly diabetic, COPD may not have angina. So the biggest thing in your clinical practice, whenever a patient comes to you, the patient has a COPD diagnosis, but when you feel that the COPD is presently not explaining the symptoms what they have, then always look for something else. So if the lung is clear, the patient is still complaining of like exertional dyspnea, which is increasing. So in that subset of patient, make sure that you go ahead and do those tests. So coronary artery disease, if they have risk factors of diabetes, hypertension, like then rule out coronary artery disease. Do a plain ECG. You can do a good 2D echocardiography. Sometimes both may be normal. The patient still would have worsening dyspnea because of an underlying CAD. If the patient is fit enough, a treadmill test is good. The second important aspect is heart failure. So Advanced COPD will present with right ventricular dysfunction, particularly when there is pulmonary hypertension and RV failure. You will have raised JVP, but that is a very late diagnosis. So these two subset of patients, conditions which would be very common in COPD is if the patient is hypertensive, diastolic heart failure. So heart failure with preserved EF is very good. Do a NT-proBNP, because I think that's the best test. Even if a breathless patient comes to your emergency and if an echocardiography is not available, do a proBNP, because if proBNP is normal, you can safely assume that that acute condition is not heart. And
If
sometimes
I would just interrupt, and you're okay, just this is for PG students and everyone, the ER that in the machine, you know, ER machines that we have the SOB profile. So as a cardiologist, you're okay with the report we get in that?
I would,
Which is
because
a mixture of D-dimer,
ultimately,
drop-I.
so whatever the report is, the interpreter are us as doctors. So we can always screen. So if we are really suspecting and if the reports are in the same lane, then it becomes better, because as doctors, we have to interpret each based on the clinical scenario. Because if the patient is interpreting or someone else is like a paramedical staff is interpreting, it's perfect, because so many acute COPD exacerbations will have a borderline raised troponin, particularly with this high sensitivity troponins, because there will be some RV strain and the troponin will be 2 times, 3 times raised. So it is a two-hit sword. But yeah, particularly if we are really suspecting something and it is falling in the same line, then we should consider it important. The third, what Dr. Abhyankar said was like pulmonary hypertension, particularly if the patient develops pedal edema, raised JVP, and he has gone into cor pulmonale. Again, we have, though my teaching for MD medicine was cor pulmonale is a very, very rare thing to happen in COPD. It's always something else. But because the number of COPDs are far higher, we do see cor pulmonale more with COPD. So kind of that is also when your patient has decompensated, the breathlessness increased, the appetite has reduced. So if he's developing right heart failure symptoms, always get a good 2D echocardiography done for to rule out cor pulmonale. And the last Dr. Madan had said was for arrhythmias. Atrial fibrillation is a very, very common arrhythmia in COPDs, particularly if there is some RA dilation. And as Sir said, theophylline and short-acting, your duolins. So if you have an atrial fibrillation already, a patient with AF coming to you, then eprevent and Budecort would be better than duolin. So something like that.
Okay, excellent.
One point I'll add to all this is one which is often get missed, particularly in obese COPD patients, is if they are snoring or not, we often miss out. And the coexistent sleep-related disorder breathing, obviously obstructive sleep apnea, and sometimes obesity hypoventilation. So these both also contribute a lot to that right-sided heart failures. And I think that also needs to be kept in mind and treated aggressively. Many of these patients actually benefit by using, say, a CPAP or a BiPAP device, particularly if it is obesity hyperventilation, then it is often BiPAP that is required, whereas obstructive sleep apnea will be needing only, simple
CPAP should be okay.
will be,
Absolutely. And very well. In fact, when he mentioned cor pulmonale, I just thought of, coexisting COPD with OSA. I just saw a patient this afternoon. Right. So one more question, Dr. Priyank, that, we always discuss beta blockers and going back and forth. So how do you approach pharmacotherapy in a COPD patient looking at respiratory safety?
So again, an important point. When I was studying, it was like avoid beta blockers in a COPD patient. So things have really evolved in the last 15 years. So why the concept of avoiding beta blockers came into existence was beta to blockade will cause bronchoconstriction, and that was the reason we do not want to give beta blockers. Now the PGs who are listening to Dr. Manu Madan's lecture, you would have heard him that the concept is give cardioselective beta blocker. Now let me really bring this into perspective. So the three most common cardioselective beta blockers which are used in practice is your bisoprolol, nebivolol, and metoprolol, right? So these would be the three drugs. Now, if you are a PG student and this is going to be your first prescription, so what should be the first choice? So for me, it would be your bisoprolol or nebivolol as the first choice, because the beta-1 selectivity is far higher than a metoprolol. So in which subset of patients you are going to continue using metoprolol? If the patient is already on metoprolol, it's a cost-sensitive scenario, though the present bisoprolol and nebivolol is pretty much of the same cost of what you're going to get a metoprolol. But if the patient is on metoprolol and there has been no exacerbations, he's tolerating it well, then continue metoprolol for that subset of patients. If you are really starting the patient on like if the patient is a known case of COPD and if as a cardiologist I have to start a beta blocker, I would select either bisoprolol or nebivolol. Now as a pure cardiologist, because we use beta blockers for angina, prevention of arrhythmias, and like the cardiac safety, coronary artery disease. So in that, bisoprolol would be a little superior because nebivolol has an intrinsic sympathomimetic activity. So a lot of benefits of beta blocker for a cardiologist comes from reducing the heart rate, which is a little inferior in compared to in nebivolol as compared to bisoprolol. So for me, bisoprolol becomes the first choice. And again, it's not me saying, there are a lot of guidelines, a lot of data, there are a lot of Cochrane analysis for the same. Now, where do you use nebivolol? So nebivolol also has a nitric oxide donor, so it helps a little better in COPD. So you have an old person where you do not want a lot of reduction in heart rate and you want to use it in COPD. So old frail person with COPD, you want to use a beta blocker where heart rate is not important. You don't want to use it for arrhythmias or you don't want to use it for something else, then nebivolol. But otherwise, as a blanket thing, bisoprolol.
Okay, excellent. Now we move to the other aspect of managing a COPD patient holistically, that is pulmonary rehab and pulmonary physiotherapy. So I'll have this question for Dr. Purvi. So see, we know that it's strongly recommended, but it's not implemented. And what are the core components of an effective PR program for us to understand, so that then we have, there is that much conviction in pulmonologists to tell this to our patients? And how can practitioners facilitate early referrals and patient adherence? Like, what can we do to solve for this problem, Dr. Purvi?
Yeah, hi. So basically, we all know, and you must all have studied also, that it's a multidisciplinary program and integrated into your COPD management or guidelines, GOLD and ATS. Everyone says that it is it is a must program integrated in your treatment, medical management. So basic components, if you see according to the guidelines, ATS guidelines or ERS guidelines, it says that the exercise training is a main core component, cornerstone of your pulmonary rehab program. But it's not only exercise training. If you see the 2023 guidelines, which says that it is not only exercise training, but changing the behavior of the patient towards the exercises and adherence of the program. That is more important. So we have to educate patient. Patient education is a core component. If you say that the patient, for me, patient education is a core component, and after the patient education, exercise training, and then nutrition, psychological counseling, and all these components come, moves around. But for that reason, first we need to educate patient, and that starts from the pulmonologist. So that's why the early reference, what we always ask for. So when you, as I think in previous discussion I was there, so you asked Dr. Manu also that Dr. Nitin, that sarcopenia is there, and we can't do anything. But if you find out this component, peripheral muscle dysfunction, early, and then that is the correct time to refer for a pulmonary rehab, because with the chronicity, as it's a systemic disorder, we all know it affects your muscular system, it affects your all other systems also. So we are there to help them to prevent these comorbidities, to reduce the problems, or because of this, whatever problems are there, that we can help them to reduce. Or maybe the chronicity, because of that there is soreness of the muscle and osteoporosis. So all these factors are managed in pulmonary rehab.
Yeah.
So exercise component is there.
Yeah. Sir, I mean, if we can, practice, that what do we explain to our patients while we are referring them to pulmonology? Like, what do you tell your patient? Why should they go to a pulmonary rehab program in simple languages?
I think it's a very difficult thing, very frankly, to convince these patients. But at the same time, I think the language that should be used is that drugs are not going to be the final answer. Oxygen is not going to be the final answer. You need to do certain things with your body, which will be in the form of movements. A part of it will be a little more exercise, and the other thing, which I put it as an argument, is that as long as you keep moving, you will live longer. Once you
I,
are bedridden, you will be sort of, in a much worse situation. So I think this is the way I put it. I
Yeah.
would like to hear it from somebody else.
I heard somebody else.
Yeah, just one thing, because this is a very important thing for us also, like people with low LVEF, and they are like decompensated. So I always put it, because these are old patients like 55, 60 plus. So I put it, your son and daughter goes to gym now. So your physio is the gym for you. So go there for an hour. This is like where you're going to meet people, and they're going to help you build strength. And trust me, they do go. And once this is like going to a gym. So once you go for a 15 days, those 15 days are difficult, but then they start loving it, and then they would do it later on. Many have shifted from physiotherapy centers to gym later on when their compensation improves.
Okay.
So yeah, this is something you can always put
Yeah,
it
very
across.
interesting. What I also start try to use is that medicine, what Dr. Nitin said, that medicine can only do this much. Beyond this, if you want a better quality of life, better outcomes for your long-standing disease, it is going to come from the pulmonary rehab. Right, great. So, Dr. Purvi, extending this discussion, that what interventions are the strongest evidence in improving exercise tolerance, muscle strength, and quality of life in stable and post-exacerbation COPD? See, you are a cardiopulmonary physiotherapist. You understand. So, suppose someone is not practicing where they have access to a cardiopulmonary system. So, then we have to actually write down and discuss with our general physiotherapists, that work with them on this. So, what should we keep in mind?
Yeah, so Dr. Sonam, the thing is, many a time it is misunderstood that pulmonary rehab is only a breathing exercise, or many a time patient says that I am doing pranayama, I am doing breathing exercise. So that is not the only thing. We see that guidelines also says, and we are in clinical practice also, we are practicing that's not only aerobic or not only strength training. It is a combination of both. If we are saying the exercise component, it is always a aerobic plus strength training. Both the exercises are as important as single exercise. And second thing, according, it is an individualized program. Like if it is a bronchiectasis patient, along with all this, we need to have bronchial hygiene component also. We need to teach them the OPEP device or whatever devices, assisted devices are required. That also we need to educate them. So it is not a single thing that, the same program goes to everyone. It is an individualized program, but according to condition you can little bit modify, like, you add this component and they can do this assisted devices also, or bronchial hygiene also, postural drainage, along with the aerobic and a strength training, and then nutrition is important along with the
So even that
exercises.
is taken care of. And even in
Yeah,
strength training, I think we have to tell them that how upper body strength training is also more important.
very important. Yeah,
Your
yeah.
respiratory muscles are involved that way, right? And they are the weakest during discharge, right? So, and to try to build them, and they are the most compliant post discharge. At least home physiotherapy can get initiated, and they can,
Yeah.
if they can, come to a hospital base, right? So, Dr. Abhyankar, talking about COPD exacerbation and when they are getting discharged, we know that a lot of the patients will have another episode or something going off post discharge. So that period is very important. So again, there have been concepts of a discharge bundle that we discuss with our COPD patients. So what are your thoughts on it? Do you endorse it? Do you practice it? How do we go about it?
Very frankly, I haven't really read discharge bundle concept in this, but I'll tell you what practical things we do. Somebody who was using BiPAP till day before yesterday and was needing it, goes home for 15 days, 20 days, and then gradually gets weaned off. Somebody who's using oxygen and needing those 2 liters will not be sent off of oxygen home, but on oxygen and then again gradually withdrawn. So I think that's the way things should be done. Somebody who is on a certain dose of steroid. I know we don't dole out a lot of steroids, but in exacerbations, we have to use steroids. And when they are on steroids, we don't suddenly stop the steroids when they are going home. We taper it in such a gradual way that they don't miss it. And when they come back, they are ready to, come out of it in a complete way. So I think that's the best idea. And
Right.
and of course, some of them actually require nebulizations to also to be taken home. I think so. So the nebulizations which they are using in the hospital, they need to take them home. And once they come for the first follow-up and you find them in a stable state, we go back to their old inhaler combinations. Usually the triple ones are the commonly used ones. But I think we don't suddenly go to the triple at discharge on all of a sudden kind of a basis.
So everything that you explained is correct. The only additional thing that they, the so-called, there is a discharge bundle concept by the BTS. What they talk about is vaccination, smoking cessation,
Oh, yeah.
pulmonary rehab. So these are the components that we want our patients to have. It's just that
Absolutely.
after an acute exacerbation, they will probably, that is the time where you can explain
Many
them.
of our patients actually the first vaccine they receive is at the on the day of discharge. The flu
Yeah,
vaccine goes in, and then
goes.
once they are back, they are ready for the
The
uh,
other thing is
uh,
that post discharge, and in our Indian context, post discharge, a lot of the healthcare is covered for 60 days. So
yeah.
I insist the patients, and when we write our follow up, like, so when we are discharging a patient, what do we write? Like, this is for PG students. You want your diagnosis, your treatment on discharge, and you want your follow up. These are the three main components of your discharge card, which is very important. So treatment on follow up is come on so and so date with so and so reports, and plan on discharge, I mean plan on follow up is vaccination, is whatever inhaler technique review, pulmonary rehab outcomes, or whatever. So this is what they mean by discharge bundle after an acute exacerbation. And if Dr. Manu, anything, do you practice that? Do you have any inputs on this?
Yeah, discharge bundle is a standard practice, although we might not be doing
In our
consciously.
head, we do it in our head.
We do it subconsciously. It might include vaccinations. It might include including the patient for pulmonary rehabilitation, checking the inhaler techniques, optimizing the management, making action plan for them during discharge, CUPD action plan, which is a mandatory thing for even NABH requirements. So all these things we do subconsciously at some level, although we might not do it as a discharge bundle as such, but I think all of us do it in a regular practice.
Right. So again, Dr. Manu, extending the discussion with you, that in our practice, we know that it's a multidisciplinary disease. We know that the patient is not only just pulmonary symptoms and issues in our COPD patients, but in practice, when a patient needs input from a pulmonologist, cardiologist, physiotherapist, primary care physician, because they're going to go back to that. So how do you manage this multidisciplinary approach per se? Like, of course, we are not doing MDDs or that kind of things in our COPD patients. So how does that look like in clinical practice for you?
Actually, it all depends on an initial workup. So if the patient has come to me for breathlessness, I'll evaluate the patient in great detail. Basic tests will be done, including HbA1cs, echos, tropies. I'll look at the BMIs. I might look at muscle masses. I might look at mid-arm circumference. I'm thinking about sarcopenias. So if I evaluate the patient in great detail, if my patient is having extensive shortness of breath, and that can't be explained by COPD alone, and markers are negative, I might even go ahead with CPET. I might call my cardiologist up and say, I'm looking for diastolic dysfunction. Everything looks normal. Please look at diastolic dysfunction as well, which might very commonly be missed. So officially, we might not be doing MDDs for our patients, but a phone call away for something you specifically need is something we should not hesitate from. Secondly, we should document everything on our papers. Many a times we write only COPD, we forget the comorbid illness. And when we don't write it, we don't work them up. And the second person who's seeing it does not know. He does not know the patient also has pulmonary hypertension apart from COPD. So everything should be documented well so that everybody is on the same page. Your cardiologist can be on the same page. If the patient has sarcopenia, you want to involve in pulmonary rehab. Again, your physiotherapist should be knowing everything. When we talk about cardiologists, you should have an echo in place. You should have specifically look for cardiac dysfunction. When you talk about pulmonary rehab, as Dr. Puri said, it's a multidisciplinary approach itself. You need a physiotherapist. You need a person from probably psychiatrist department to look at anxiety, depression. You want smoking cessation. You want probably cardiac clearance up front because these patients have cardiovascular comorbidities. If they are fit enough to undergo exercises, you want a dietitian, of course, a pulmonologist will be there. So these are things where you can involve MDT and multidisciplinary teams to evaluate your patients.
And what you're describing, it's in real life how this leads you. It's almost like you are the captain of the ship and you are coordinating everything. So when the patient has come to you with an acute exacerbation, it's your job to understand what the cardiologist is thinking so that you know that what to look for in follow up and when to send them back to the cardiologist. You have to understand the diet plan, what the dietitian has given, so that when they are coming for follow up with you, you know whether that has happened or not. And the same goes for the so we have to really pick up the phone, call our physiotherapist. Okay, how is the improvement? What is the thing we expect? So that there is a common communication that goes to the patient.
Same as
So
for the GPs, I would say, like if you have documented that I have given the vaccination for this year, the next vaccination is due next year, this year is done. So that your GPs also know that vaccination is scheduled for next year. If the patient doesn't come to you, GPs are giving that. You can obviously write that inhaler technique needs to be checked. If the patient doesn't come to me, goes to the GP, he'll make sure the adherence is there. He'll make sure the technique is fine. So if you document everything well, many times the need for MDTs are obliterated, but phone call to your specialist always helps.
And we used to, wherever you are, so in a private setup we have, I and many practitioners I've seen, they have like a thing printed on their file only, the vaccination, this, that. So it just gets documented on the file. I've worked with the railways in the past. They used to have a book, so we had made a simple stamp, ink stamp, and just put it at the start of the book, so that even if, because duties change, right? Even residents, you guys may not know what has happened 3 years ago. So each department, if you can have just simple low cost intervention where documentation is correctly done, it could work wonders for our patients. Dr. Abhyankar, I think you wanted to say something.
No, I think that's the simplest we do is we just, whenever we inject a vaccine, that gets stapled to the paper, to the paper. So, automatically, particularly for influenza vaccine, that becomes a good reminder because they look at the date when it was given, and automatically next year, the first year is your worst year. The second year, third year onwards, you don't have to remind them. They remind you about the vaccination.
True. Excellent. I think we've had a good discussion. We've covered many things. If anybody has any closing remarks, closing thoughts, otherwise we will now move to the postgraduate quiz section of this program. Anything, Dr. Purvi, Dr. Manu?
I think what Dr. Priyank said, I would reopine the same. Regarding that, your first workup is very important. Once you have labeled the patient as COPD, most of the time you're not going to change your diagnosis. You're not going to review the diagnosis until this patient is becoming sick. So your first diagnosis and first workup should be really good so that you don't miss out on finer details of the patient.
Yeah. But I would like to add on that you always have to keep in mind that every time the patient is coming to you, you have to think of it with a fresh, like the commonest example is like I have a patient of severe asthma on benralizumab. Patient was just not, he was having breathlessness, cough. We kept thinking that it's a failure. I involved the cardiologist one, but after the day 4 is when the tropi went ahead, and it was an ischemic event that kept happening. And it can happen at any time. You can optimize, but yes, after you optimize the patient from a pulmonary point of view and still the patient has symptoms, you dig deeper, even beyond your routine blood work and opinion. You have to think like that. So every episode, every exacerbation, you rethink and come back to, because in clinical practice you'll keep getting these googlies, because what Dr. Modi mentioned, that anybody can have a MI at any stage. It does not matter if I've screened the patient today, the next year they can have a myocardial infarct. So keep everything in mind, and yes, that's about it. I think
I think regarding the workups, as you said, the patient can have MIs. So whenever I get a student who asks me that patient has come in type 1 respiratory failure, I'll ask him to look at all the possibilities.
Yes.
Look at pulmedema, look at embolism, look at pneumothorax, look at pneumonia, look at if the patient is a known case of asthma, look at acute exacerbation of asthma as well. So you have to look at the patient holistically, not just that lung is the source and only lung has only obstructive airway disease, it cannot have anything else.
Yes. Yes. Excellent. So anybody else? Otherwise, we move to the quiz section. Sanjana?
Ma'am, we can move on to the quiz.
Okay. Okay. Are there any questions in the chat that I'm supposed to take, or the panelists?
No. If there's anything, I'll let you know, but I think we can move on to the quiz.
Okay. So who's can somebody share the screen, please? The questions. Right. And everybody is you will guide me, right? When I can see the results.
Yes, ma'am. We will share the result.
Sure. Right. So this is the first question. All of the following statements are true regarding the major trials in triple therapy, that is ICS, LABA, LAMA in COPD, except the IMPACT trial demonstrate a reduction in moderate to severe exacerbation compared to both ICS, LABA, and LAMA. The IMPACT trial demonstrated a reduction in moderate to severe exacerbation compared to ICS, LABA, and LAMA. The TRibute trial demonstrated statistically significant mortality benefit with triple therapy, and the Chronos trial included patients without a history of frequent exacerbation and showed improvement in lung function. I think 10 seconds to this, and then we can move to the next question. There was some issue with the option B, or at least what I can see on my screen, but let's see. Okay, we move to the next question. Have you got enough people answering? Yeah. So the second question is, which of the following FEV1 trajectory patterns over the life course is described in the Goal 26 report is most directly associated with development of clinically significant COPD in a non-smoking adult from an LMIC or low to medium income country? Supranormal FEV1 trajectory with accelerated decline after the age of 50, normal peak FEV1 attainment following age appropriate physiological decline, failure to achieve normal peak lung function due to early life events such as premature birth or low birth weight resulting in a below normal trajectory, and normal peak FEV1 with abrupt decline due to a single environmental exposure episode in adulthood. I think wait 5-6 more seconds and we move to the next questions. Right, question 3. Okay, which of the following statements best describes the evidence supporting the use of single inhaler triple therapy compared to dual bronchodilator? So triple therapy provides superior symptom relief but has no significant impact on exacerbations compared to LAMA. Triple therapy suggests a beneficial effect on mortality in symptomatic COPD patients with a history of frequent or severe exacerbation. Triple therapy is preferred initial treatment for all newly diagnosed COPD patients who are highly symptomatic, regardless of the exacerbation history. And triple therapy reduces mortality risk but is associated with a lower improvement in lung function compared to ICS LABA. Right, move to the next question. Question 4. According to the Goal 26 guidelines, which of the following statement regarding smoking cessation in COPD is correct? E-cigarettes are recommended as first-line smoking cessation aid. Brief cessation counseling by healthcare professional does not significantly improve quit rates. Nicotine replacement therapy and pharmacotherapy reliably increase long-term abstinence rate, but there is currently no evidence to support e-cigarette as an effective safe cessation aid, and legislative smoking bans have no impact on population level quit rates. Right. We'll go to the last question now. Question 5. A 68-year-old man with gold grade 2 COPD presents with low mood, progressive weight loss, BMI of 19 kg per meter square, mild anemia, increasing forgetfulness. According to the Goal 26 morbidity cluster framework, which of the following best characterizes this presentation? So these findings are unrelated to COPD and should be managed by separate specialists independently. This presentation spans multiple comorbidity clusters: the mental cluster, depression, cognitive impairment, and the MALT cluster, anemia, low BMI, each independently impacting outcomes and requires active identification and treatment. Low BMI in COPD is associated with improved survival, and anemia is of no prognostic significance. And depression and cognitive impairment in COPD are expected age-related changes requiring no specific intervention. Okay, I think we can close. That's enough time to answer these questions. If someone can display the results.
Yes, ma'am.
Right. So the first question was, which one is not true? So the tribute showed exacerbation reduction, but no significant mortality benefit, which is why the correct answer is C. Next answer to question number 2. Yeah, we were seeing that which is the COPD. So in a low to medium income countries, COPD can develop not only through accelerated FEV1 decline, but also through failure to attain the normal peak because of early life disadvantage like premature birth, low birth weight, and childhood respiratory infections. Next. So this is the third question about triple therapy. So we say that the triple therapy has beneficial effect on mortality when compared to fixed dose LABA-LAMA combination, specifically in symptomatic COPD patients who have a history of frequent or severe exacerbation. And triple therapy has shown to improve lung function, symptoms, health status, and reduce exacerbation more effectively than LABA-ICS or LABA-LAMA or LAMA monotherapies. Fourth one about smoking cessation. The correct answer is C, that nicotine replacement therapy, pharmacotherapy like varenicline, bupropion, nortriptyline has proven aids to long-term abstinence. Critically, despite widespread patient use, the guidelines explicitly state that there is no evidence to support effectiveness and safety of e-cigarette as a cessation aid, making this high-yield clinically relevant distinction. And A and B are direct contraindicated by the guidelines, and D is incorrect as legislative bans have improved quit rates alongside healthcare professional delivered counseling, not just by itself. Next answer. Yeah, this is the, the framework and the cluster that has been described. That is the MOLT cluster. So our patient was 68, had low BMI, had anemia. So the 2026 GOLD guidelines identify 5 morbidity clusters that independently impact outcomes. And this patient's presentation involved mental status, that is depression, cognitive impairment, and mold cluster, multiple organ loss of tissue, anemia, sarcopenia, low BMI. Critically, BMI below 21 is explicitly associated with increased mortality of COPD, and the guidelines advocate that person-centered 4M framework, that is mentation, medication, mobility, and morbidities, to comprehensively address such multimorbid patients. So CND are contraindicated by the guidelines. So I think this is it. These were the 5 questions. How are we going to have the answers? How give the results to the students?
Yes, ma'am. Just a minute. I will
Sure.
share.
You let me know whenever you guys are ready.
Yeah, just a minute.
Okay, so this question, many people got it correct. %57%. So this is where we had a divided house. So very specifically to LMICs, it is the fact that we fail to achieve the normal peak early, like because of early life events, and that is what contributes to the COPD in LMICs. Okay, so no confusion here. Everybody got it. Okay, so again, divided house here, but brief, actually, smoking cessation counseling, even for 5 minutes by healthcare professional, does contribute to helping quit rate. So I think every time we meet our patients who are still smokers, it's our job to not make them feel wrong about it, not make them feel guilty. At least they'll be honest with us and go over the same things. Probably it's the same thing that you have to tell them at every follow up, but go over the issue and why are they failing with their smoking cessation patterns, and whether they want to try other things. Very often nicotine replacement patients have tried on their own, in practice, and whether they are willing to do the counseling, they are willing to go on to pharmacotherapy, understand the pros and cons of pharmacotherapy, and then I think you should, as clinicians, we should always reach out to them again. Next. Okay, the next, again, divided house, but this is clearly the MOLT, that is multiple organ loss cluster, which is described in the GOLD 26 guidelines for COPD patients. All right. So, are we waiting for anything else, or?
No, ma'am, we can wrap up.
Yeah,
If there
we
are
can
any
wrap
closing
up.
remarks, we
Yes.
can.
To all our panelists, our speaker, really appreciated. What a lovely discussion this was. And I hope the postgraduate students found some benefit in clearing certain concepts, and not just from a theory point of view, but something that they can apply and, take home on a day-to-day basis when they're seeing patients day in and day out. And yeah, that's about it. If there is any feedback, please let us know. And any if Dr. Purvi is here, I believe Dr. Abhyankar is not with us, but if Dr. Manu Madan, any other closing remarks? Dr. Modi, anything? Otherwise, we can close this session.
Yeah, I think it's a wonderful concept, and we take up the small topics which are actually pertaining to relevant to our clinical practice, and then we discuss it in minute details, and it's a very good concept. And I hope the students get to learn something from this.
Yes, yes. And I believe this gets broadcasted to the students later on, even if they've not managed to see us live, because we can imagine it's a middle of the day. I don't know how many postgraduate students were attending this, but I'm sure even if they look at it later on, it's been a great discussion. That's it. Thank you. Thank you, Sanjana. Thank you, the backend team.
Thank you.
And we can close it.
Thank
you,
you
Dr.
so much.
Dr. Modi, all of you all.
Thank you.
Thank you everybody for joining, and thank you Dr. Sonam for excellent moderation. I think such a lively panel and really wonderful insights as well. So thank you all so much for joining us. We look forward to hosting you all very, very soon. Thank you.
All right. Bye-bye.
Bye. Thank you.
Yes, thank you so much everyone for joining today's session. So from here I'm ending this meeting. Thank you.
Thank you.